Hello everyone. We are very pleased to start the new webinar series, and with a special thanks to Dr.
So we are
Shalini.
live now.
Are we live now?
Yes, we are live.
Okay. So, hello everyone. We are very pleased to start the new fourth Thursday, the special webinar series, and special thanks to our Chairman Scientific Committee, Dr. Shalini, who will be organizing this meet every month so that we can have a regular meeting and update regarding a recent topic which is very important for all of us. So this time we are having this webinar on PUK, that is peripheral ulcerative colitis, and we have two very eminent scholars with us, Professor Radhika Tandon, who is the chief of RP Center, and Dr. Somshila Murthy, who is presently in Bombay but was a fellow and consultant at LV Prasad. So, and I have a personal experience with both of them, and both of them are really excellent cornea surgeons, and they have been doing great job. So, with these few words, I invite Dr. Somshila for her first lecture, and I think Dr. Shalini, who will introduce. I will first invite Dr. Shashank, our president, to welcome the guest and start the seminar.
Thank you, Dr. Abhishek. Respected Dr. Kamaldeep sir, Professor Speaking sir, और हमारे सभी सीनियर्स, ये अभी हम लोग का टीम बनने में जो कि बहुत ही एनर्जेटिक और टाइमली टीम है, सब की साइट तक गया है, साइट को और ऊपर बढ़ाने में जो बिना रुके शुरू कर दिए हैं, इसके लिए हम अपनी पूरी एग्जीक्यूटिव टीम को हम चला देते हैं। आज वेलकम सबके साथ आपका बंधन में सबके की बात थी ये all of them. Thank you. Hello.
Hello. Hello. Good evening to every one of you. Myself, Dr. S.P. Singh.
Good evening, sir.
No, say, thank you so much to everybody.
Namaskar, sir.
And all the executive, namaskar. All the executive members, newly elected or nominated members, respected members. Thank you very much. And I would like to congratulate all of you for organizing this academic meet. We are very happy that at least UP should lead in academic field. This is our feeling and the feeling of all the seniors and all the executive as well, and the past executive also. We want their participation, active participation, suggestion. Most welcome to everybody. Dr. Mohita and Dr. Dharmendra and all other past our respective presidents, to everybody. Without delay, you can start now.
Thank you, sir. Thank you.
And so, also, I welcome to this speakers guest. Yes, I know everybody. And Dr. Radhika as well. Dr. Radhika and Dr. Somshila Murthy. I met personally Dr. Radhika in number of occasions. We have in the NMC office as well. Thank you very much to everybody.
Thank you, sir. Thank you. So today we are having two stalwarts of cornea specialists, with whom we are going to have this wonderful webinar. And so I would request Dr. Saqib to introduce Dr. Somshila Murthy, who has agreed on this wonderful topic of peripheral ulcerative keratitis, and especially for general ophthalmologists, because this topic is so important and many a time it is a mixed diagnosis also. So I would request Dr. Saqib to introduce Dr. Somshila.
Thank you. Good evening, everyone. On behalf of UP State Ophthalmology Society and Honorable Chairman Scientific Committee, I have privilege to introducing our esteemed speaker, Dr. Somshila Murthy. Dr. Murthy is distinguished ophthalmologist and eminent leaders in the field of cornea, cataract, and refractive surgery, uveitis, and ocular inflammation. She completed her medical training in the Mumbai, followed by the prestigious cornea fellowship at the LV Prasad and fellowship in uveitis and oculopathology from the Donny Eye Institute, USA. Since April 2023, she has been serving as the founding medical director of the Shantinal Sanghvi Eye Institute, Mumbai. Her academic and research contributions are truly noteworthy. With a special focus on uveitis and trace segment inflammation, she has participated in over 20 clinical trials, published more than 250 scientific papers, authored 15 books, chapters, and one textbook, and delivered over 300 podium presentations. Her excellence has been recognized through the numerous prestigious awards, including AO, AIOC, and WS Leadership and IRC Gold Medal Award and IGO in 2024. So, again, welcome you, ma'am. Thank you very much.
So with this amazing profile, I would request Dr. Somshila Madam to kindly start her presentation.
Thank you so very much. At the onset, I would like to thank Dr. Shanti Mohan and all senior members, Dr. S.P. Singh, Dr. Sakib, and everyone who was involved in the UP State Society. Thank you, Dr. Shashank Kumar, of course. Thank you so much for this invitation. Going on to the topic, I'd quickly like to acknowledge that this topic, most of the learnings and teachings I have are because of my stint in Eri Prasada Institute, and currently I'm on deputation, and I do intend to go back to Eri Prasada Institute eventually. So this is one of my favorite topics, as people have trained with me. I'm sure Dr. Archana, they all know about it. But I'll try my best in a simple way, how, as a general ophthalmologist, or those of us who practice maybe in a smaller place where we have to take care of the patient end to end. So we can't just afford to send the patient away and say that, we don't look at these cases, so please go to the specialist and so on. So let's understand about this disease, and let's have a practical guide on how to manage these cases. So we all know that peripheral ulcerative keratitis, that's what PUK stands for, but it's a very broad umbrella. It includes both the true, when you say PUK, you immediately think of immune-mediated PUK, and you think of conditions like rheumatoid arthritis or the other systemic conditions. But you can also have many lesions that have ulcerations in the periphery. So that is also PUK, so PUK-like lesions. So any condition where you have peripheral ulceration of the cornea, we can label as PUK. But true PUK is very rare. However, PUK-like lesions we can see much more frequently. And they can be very simple lesions like even marginal keratitis or some other infections and so on. So what are all these conditions? We'll try to quickly go through them. First of all, what is textbook definition of PUK? That is a classically immune-mediated peripheral ulcerative keratitis. It can involve only the eye, or it can be associated with systemic autoimmune disorders, and it has a high association with connective tissue disorders, perhaps around 50%, which includes rheumatoid arthritis and granulomatosis, polyangiitis, to name a few conditions. Sometimes it's very important for us as ophthalmologists to recognize the immune-mediated PUK, because the ocular manifestations can precede the systemic disease, and this has been shown in studies. It can precede it by several years, in fact. So you may be seeing at a PUK today, but the patient may turn out to have a systemic connective tissue disorder later on down the line. So let us revise the clinical features of all such cases. So most of the time it's unilateral, but you can also have patient with bilateral presentation. Bilateral at the same time, meaning simultaneous, is a little rare. So you can have sequential presentation, first in one eye and then the other eye, especially when the cause is a systemic cause. So the classical picture is having a precentric perilimbal corneal ulcer, so peripheral corneal ulcer. The edges of it show infiltration, as is there in this clinical photographs. And that ulcer keeps spreading circumferentially, because in case it is left unchecked, then it can also spread centrally. So this is the classical picture for an immune-mediated ulcer. When the clinical picture does not behave like this, for example, instead of seeing circumferential spread, you go on seeing a central spread, then you think of a PUK-like lesion. A classic example of a PUK-like lesion which starts spreading centrally would be an infection, maybe herpes and so on. So in addition, there'll be spread, there'll be thinning in the conjunctival tissue, the episclera, the sclera can also sometimes get involved. if the inflammation is continued to be unchecked or not treated adequately, you can have an anterior chamber reaction like even a hypopion. So these are some of the features where in this case there is actually this looks more like a Moran's ulcer. So there's a classical peripheral ulceration with the overhanging edge. And about this area where you see the brownish tissue, there's almost a 90% or 100% melt over here. And the brownish tissue, the iris is just about to pop out. And the inflammation is so severe that you can see that the pigments have deposited on the anterior lens capsule because of the severe anterior chamber inflammation in this patient. This is a rare example of a patient who presented to us with bilateral simultaneous onset, which is again, as I mentioned, very rare, which was separated a few days apart. So these are the pictures of the right eye. The patient presented with this peripheral ulceration and melt in the center, which did not improve after simple application of glue. So ultimately, we had to do a small patch graft. This was the other eye of the same patient showing peripheral ulceration, which was a much larger peripheral ulceration. So we did not bother to do glue or anything like that. We just went ahead and did a corneal patch graft and an amniotic membrane graft for the patient on the surface. Of course, we investigated this patient. The patient turned out to have RA factor positive, but did not have rheumatoid arthritis by itself. Just the factor was positive. So we also started the patient on oral steroids as well as azathioprine, and that's how we control the disease. You can see that the inflammation was so severe that the patient even had a hypopion at onset itself. So this was an untreated and more severe case. So as a general ophthalmologist, you'll ask me that, okay, that's fine, but what is the relevance to the general ophthalmology clinic? How often am I going to see these cases? So immune-mediated PUKs, thank God, they're quite rare, but they're not infrequent. It's not zero. So because of our population being huge, we will end up seeing these cases very infrequently, though. Whereas Moran's ulcer, the frequency increases in the population. Again, Moran's ulcer is rare, but in an Indian population, for some reason, it is not that rare at all. So most ophthalmologists, as you practice for years and years, are very likely to see these cases of Moran's ulcer. If I ask everybody today who are connected online, how many of you have not seen a Moran's ulcer? I don't think there's anybody who's not seen a Moran's ulcer unless you're extremely very young. And the PUK-like lesions, these are the mimickers of the classical immune-mediated PUK. Each and every general ophthalmologist will definitely be seeing these kind of lesions. So for a general ophthalmologist, the third part, the PUK-like lesions, we must know how to recognize them. The second one, that's Moran's ulcer, we should at least know what it looks like and be able to start a first level therapy. Whereas the first one, that is immune-mediated PUK, which is very rare, perhaps these conditions, you can stabilize the eye, but you can quickly refer these cases to those who, a specialist or an institute set up. Because the very first one, the immune-mediated PUK, will be associated with systemic disease, which is rare, but we should be able to recognize these conditions and refer these conditions. This is a good old example of, it's not very clear because the patient also has scleritis here as well as has peripheral ulceration. So this with infiltration at the leading edge of this ulceration. So this is a patient more likely to have one of the systemic conditions, and it is not just ocular alone. So this kind of patient, maybe we are better off referring to a higher center. So to manage these conditions is to understand what's the etiology. I would broadly classify them as local causes and then systemic causes. And there are a list of them, but I'll simplify it for everyone. So local causes can be infectious, which can be anything. It can be bacterial, fungal, can be viral is notorious, can even be acanthamoeba. Sometimes these can present peripherally, though it's rare, but they can present as peripheral corneal ulceration. But viral classically can do that. So if you have what looks like, and I'll show you an example of that, how a viral can mimic a PUK. Non-infectious is what we had discussed just a little bit earlier, is that you can have under non-infectious, you can have certain conditions which are mimickers, PUK-like lesions. So it can be just a trauma. So imagine that you have trauma to the inferior part of the cornea and that area is eroded and the patient comes to you, you see peripheral thinning and you might assume it's a PUK. So make sure, of course, that you elicit history of these kind of trauma. The lids and lashes, especially if there is some exposure or if there are inturned eyelashes, it might keep on eroding the corneal epithelium and ultimately you'll have ulceration. Neurogenic cause, and sometimes rarely masquerades can also look like PUK. So make sure that we take a very thorough history for these patients. And of course, I mentioned Moran's earlier, which is an immune cause. Some of the systemic causes which can cause PUK include RA with, I think I'm coming to that. Under dermatological, we can have something like SJS, which because of the dry eye can resemble PUK, and certain systemic infections, which I'll just omit for the sake of simplicity. So coming to the systemic causes, as I mentioned, we have rheumatoid arthritis, we have granulomatosis, polyangiitis, earlier called as Wegener's granulomatosis. We can also have relapsing polychondritis and SLE. These are the top 4 conditions. Most of the time, 90% of systemic association is with these top 4 conditions, and they're very classical. So if you want to elicit history, it's very easy to elicit for these 4 conditions. And you can have rare cases as well. Dermatological disorders is cicatricial pemphigoid and SGS. So these are 2 examples of PUK-like lesions. This is not the classical PUK. This is a patient very congested eye, as you can see, and has a peripheral ulceration, which is creeping centrally. So there is thinning here. There are vessels leading up to that thinned out area. So as the ulcer is creeping centrally, there is some peripheral healing or response that is taking place. So when the patient came to us, patient was diagnosed as a case of PUK and referred accordingly. But what we noticed was this whitish looking infiltrate. And as you know, in viral, because of the sort of, because of the patient hardly has doesn't have severe pain or severe sensation sometimes. So you have that the pain is disproportionate, very low as compared to the amount of inflammation you're seeing. So that's one classical telltale sign. Whereas patients with that classical advanced Mohr's ulcer do have severe pain. So this patient, we, apart from using topical steroids, also have to start antivirals, and the patient responded very well. There was another patient we saw who had this peripheral ulceration. It's difficult to see, but had this whitish lesion on the cornea and a very white looking, keratotic looking patch over here. Initially, we only thought that this is kind of peripheral ulceration, but luckily for us, we realized it's not. And our surface colleagues, our plastic colleagues diagnosed this patient as having OSSN, ocular surface squamous neoplasia. So these are some of the rare. So OSSN is rare, but HSV is not at all rare. So how do we reach a conclusive diagnosis? Here we could take microbiological scraping, we could subject it to PCR for HSV, or we could rule out secondary infection in such cases. So what about classic Mohr's versus something very, very mild? So on the left side, we have Mohr's ulceration here. This is classic Mohr's. So we have peripheral crescentric thinning, which is spreading circumferentially. Usually there's nothing in the limbus or beyond the limbus, there's nothing in the sclera, there's no scleritis, and there's overhanging edge with 90% thinning. So these are some of the classical features of Mohr's, which is enough for us to diagnose the patients as Mohr's ulcer. Sometimes something very, very simple and very innocuous. This is a patient who was a contact lens wearer, presented with recurrent redness and also with small peripheral lesions. So these are typical sterile infiltrates which contact lens induced. Unless you elicit the history from the patient sometimes doesn't tell us, then you might keep thinking that this is some kind of inflammatory condition and you will start treating the patient with topical steroids, little knowing that it's the contact lens that was the offending agents. These are actually real life cases, and that's the reason why I'm mentioning here. Remember that patients don't understand that giving us a history of whatever's happening to their eye is important. They think it's unrelated. We can also have ectatic conditions like pellucid marginal corneal degeneration, where inferiorly there's a lot of thinning. So sometimes we might miss that this is a case of ectasia, like a PMCD, and instead we might think that this is a resolved PUK. That has happened to us. This is that OSSN patient who earlier was very early in the clinical picture. Actually, now in retrospect, when I see the pictures, I think that it looks very classical. But at that point in time, we saw there's peripheral ulceration and a lot of inflammation. So we labeled this patient as some kind of PUK till the actual clinical picture evolved. Then you can have our usual enemies like a bacterial corneal ulcer. So the bacterial corneal ulcers occur very rapidly. So the patient develops a corneal infection, and unless you start the appropriate antibiotics, suddenly there'll be melt and you'll see the iris popping out because of the severe inflammation as well as the acute attack that the tissue is undergoing, and because of the enzymes released by the bacteria. So this is a case of a staphylococcal ulcer which perforated very rapidly. But this is peripheral, this is ulceration. So yes, it is a peripheral ulceration, but it is due to an infectious cause. So we have to make sure that we don't mislabel it. So here you see there's no hypopyon. You can sort of say that, okay, this looks almost sterile. Then you'll be wondering what this is. So we did corneal scraping. Of course, we did tissue adhesive and bandage contact lens as well to take care of the perforation, and we identified bacteria from this patient. Sometimes the reverse can happen. You might see a patient with very advanced, this is a patient with very advanced Murren's ulcer, where literally most of the cornea is destroyed and only the central stroma is still intact. Peripherally, there's staphyloma formation and so on. And this patient was actually referred to as a case of severe infection. So it was thought that this area, which is actually severe edema and inflammation, is an infected ulcer. So this was an advanced Murren's ulcer with a sort of a mimicker of infection. What do you think these images represent? So the same patient, this is the right eye, and the picture on your right side is the left eye. So what strikes you in the right eye is that there is a peripheral melt. So is this PUK? There's peripheral melt, the eye looks congested, and there is some inflammation or some infiltration at the leading edge. Now, I showed you in slide 3 or 4 that these are the classical pictures, these are the classical features of PUK. So is this PUK? The answer is obviously no, it's a mimicker. So why? When you see the other eye of the same patient, of course, there's no PUK here, but see the lusterless cornea. So this is actually a patient of dry eye. So this patient had Sjogren's syndrome and with severe dry eye or keratoconjunctivitis sicca, with Schirmer's literally almost zero. So this is not PUK, but this is simple desiccation. So the cornea is so dry that it's just undergoing desiccation or destruction. And you have to intensely treat this patient with lubricants and maybe address the systemic part if the patient has RA or something like that. And then do a tassuraphy, do punctal cautery, whatever can be done to salvage this eye. So this is not PUK. This was a patient with Sjogren's syndrome, again referred as a case of PUK. So this is the other eye. When you apply fluorescein stain, also you can see that how much of the cornea will stain with it. Yet another case where you can consider this as PUK, but it's not. So this is also Sjogren's syndrome, where because of the corneal thinning, there can be perforation as well. So this is, it's not ulceration. It is thinning due to melt of the cornea. So there's a difference. And in this patient, again, we had to stabilize by doing a tissue adhesive bandage contact lens, and also a punctal cautery and a paramedian tassuraphy was done for this patient. But of course, the disease continued for this patient. And I think we didn't have a great outcome at the end of this case. A few more mimickers. So Terrien's, as you know, it's a condition which is idiopathic. That means the patient presents with peripheral thinning and pannus formation at the periphery. And classically, it is supposed to be superior, but here we had a patient of inferior Terrien's, which was so some of these patients with Terrien's, although it's supposed to be a non-inflammatory condition, but sometimes they have some congestion in the eye. So this was a patient referred as PUK. But when you see the slit view, you can see how there is this ectasia. You can also do pentacam, and you'll see the classic features on topography for Terrien's marginal degeneration. This is a degenerative condition. It is not PUK. There's never any ulceration in these patients. This is how classically Terrien's appears. The superior thinning with lipid formation at the leading edge, non-inflammatory, and there'll be visible vessels or like a pannus, replacement of the tissue like a pannus. And you can see how thin this cornea is over here. So in a nutshell, the management of PUK depends on the etiology. So if it is immune mediated, especially locally immune mediated conditions like say Murren's ulcer, there doing a conjunctival resection and glue application is a first step number 1, and intensive topical steroids based on the degree and severity, so and the age of the patient. So intensive topical steroids, also oral steroids, and also oral immunomodulators based on how severe the case may be. All of these are what we need to resort to for a case of Murren's ulcer. So it may range as simple as only focal 2-3 clock hours of thinning, or it may be very severe, it may be bilateral, in which case, or it may be a young patient, or it may be one-eyed patient. So in which case, I usually go very aggressive, start the patient on immunomodulators, sometimes even cyclophosphamide, or sometimes even biological agents for these patients. Otherwise, you can't salvage the eye. I'm just, do I have any time or do I stop now? I had one case to present.
You can continue. You can continue, madam.
So this is just one interesting case recently managed, co-managed, so by Dr. Vishram Sangeet and us. So this is a youngish lady, 49-year-old with diabetes, presented to him He's also located in Mumbai, and he was managing the patient. But the patient came to him with bilateral Murans, so he did a conjunctival resection and glue BCL twice actually. The patient was on oral steroids, but they had to take the oral steroids off because of the diabetes. The patient received cyclophosphamide, but only 1 or 2 doses, and then they stopped that. So you know how sometimes the patients come and then they are lost to follow up, and then they come back later when there's worsening. There's some such case. So this is just sequentially showing you how the course went for the entire 1 year. He did conjunctival resection, glue BCL. 3 weeks later, not much better. 3 months later, there was obvious worsening. Patient disappeared and reappeared at this point. And then at the end of 5 months, the patient had severely worsened. There was very active disease in both the eyes. All the time, the patient was on topical therapy and using steroids, sometimes not using, very irregular in that way. So the case was referred to us at Shantilal Sangha Institute. So she had no scleral involvement. There was nothing systemic, like, for example, no features suggestive of rheumatoid arthritis. And we did a workup. All the investigations were negative. So this is how we received the patient, bilateral, very severe disease, as I showed in the previous picture, almost bilaterally blind with counting finger vision, and left eye was counting finger 1 meter. So we also even suspected secondary infection because of the dense hypopyon here, but luckily there was no infection. We did corneal scraping that was negative. And then ultimately we repeated the glue BCLs for the eyes. We applied amniotic membrane. We started IV methylprednisolone followed by oral steroids. And although we referred the patient to rheumatologist to start rituximab, but the rheumatologist decided to start adalimumab, which was a good decision actually in this patient. So as you know, rituximab works on B cells mainly, and it's a very good biological, and its dosing is it may be 2 or 3 doses, but it's extremely expensive. Whereas adalimumab is very much indicated in patients such as RA positive patients and so on. And adalimumab needs many more infusions, but overall, the therapeutic efficacy is extremely good and has been shown in many studies. So this is after the glue BCL and AMG. It looks a little bit of a mess. This is So this is the right eye and the left eye. The left eye was always luckily a little bit better than the right eye. And anyway, we thought that the right eye we've lost the right eye. We said that we'll try our best for the left eye, but right eye is something that we cannot predict. 3 weeks later, slightly better, not that much though. And this is 2 months. The patient had received ADA, maybe 6 infusion by this time. So now we can see that the right eye appears slightly better. Left eye definitely is getting clinically quieter. 3 months later, we had to repeat a multi-layered amniotic membrane because there was activity still in the right eye. So we repeated amniotic membrane for the patient. And now the left eye looks so much better. You can actually see the anterior chamber contents for this patient, and all the inflammation of the cornea is subsiding, the melt is subsiding. So she completed 21 injections of ADA and tapering doses of oral steroids. We started on methotrexate, and of course, topical steroids are going on. The surgical interventions included amniotic membrane, glue BCL in right eye and left eye as well. So this is the left eye. At this point, she was awaiting cataract surgery. Subsequent to that, I completed the cataract surgery in the left eye, and her vision recovery was 20/40 in the left eye. Eye is very, very quiet. And the right eye also, which we thought was a lost eye, actually is extremely recovered extremely well. And we're just waiting. She doesn't want a cataract surgery right now, so we're just waiting for her cataract surgery, which I'm sure after which her vision will become much better. So this was a case of very severe bilateral Murans, not languishing, almost losing vision, and could be rescued because of very aggressive immunosuppressive therapy with biologicals. So nothing we did as ophthalmologists, but more that the rheumatologist helped us for this patient. So we need to be that aggressive sometimes. So in summary, PUK and PUK-like conditions are similar but dissimilar, because if in true PUK, it's going to be immune mediated. And the example I showed you is one such example where we need to be very aggressive. Whereas the PUK condition-like conditions can be extremely simple, and all general ophthalmologists can recognize them and treat them. So the true PUK, perhaps we can refer to the referral centers, to the institutes and so on. But the PUK-like conditions that I pointed out earlier, I think we as general ophthalmologists can definitely often treat them with satisfaction and with good ability for resolution of the condition. So that was my conclusion slide, and thank you so much for your patient listening to me.
So thank you so much, Dr. Somashila, for your wonderful talk. and it was really very inspiring. And we saw such cases. One question that comes to my mind is, how did he operate on that cataract? Because the periphery was extremely difficult to do a phaco or something in that
No,
case.
excellent question. I have recorded, I'll share the surgical video sometime. But I did a temporal, it was a left eye, I did a temporal incision uh, at the sort of
Mm,
the, or maybe I did at the clear cornea, at the limbus actually, almost in the sclera, to avoid that very much thinned
mm,
out cornea. So wherever I found a small window, it was actually superior temporal, there was a small window where the cornea had not completely melted. Then
mm,
my side port gave through, so I had to suture that area and I had to put my side ports literally somewhere very far off. So it was a bit of a struggle. In fact, I sutured everything. There was a
mm,
leak on the first day. I went back again and sutured that. And I had to apply glue on the side port, tissue adhesive on the side port to make
mm.
it stick the next day. So it was not easy actually. Correctly recognized.
Yeah.
Yeah. It was very challenging.
Uh,
Yes. Thank you so much, madam.
Dr.
Dr.
SM, I
Shalini?
have a query.
Yes, please.
In the
Yes, yes, sure.
last case, which you managed so nicely, at no point you used lamellar corneal patch graft.
At no point. So that's exactly. So I have moved out of doing lamellar corneal patch grafts for cases of Murins, because the problem with patch grafts is that we are again providing the same antigen to the disease which it's attacking, like the stromal keratocyte. So you know that the antigenic tissue is a stromal keratocyte. So do not do a corneal patch graft. Do anything but. So glue BCL, amniotic membrane, Tennant's patch graft. I'm a big fan. So Tennant's patch graft wherever possible, and immunosuppression. Yeah,
Yes. So
immunosuppression.
up to how many clock hours you used Tennant's patch graft, and beyond that, combined.
So for these earlier days where we used to do these large banana patch grafts,
Yes.
so unless it's a huge perforation, which would be more than 5-6 millimeters along its vertical end, anything short of that, I would definitely go with the Tennant's patch graft and then stuff the remaining. So you know that in one area it will be full thickness, remaining area it's crater deep. It's like very, very thin, but not everywhere has it perforated. It's not a large perforation that way. So the remaining areas I would stuff some amniotic membrane. So combine the two tissues, amniotic membrane, because you'll get the collagen part of it, and Tennant's patch graft has its great properties. It's easily available. I mean, if you have only Tennant's patch graft, then just use that. But it's available in the eye and it's an easy enough technique and so on.
Yes.
But if it fails, though, so we do all that, and sometimes it fails, it doesn't hold. Then I go in and do a corneal patch graft. So I had a recent patient where the patient came back again, similar case. We did a Tennant's patch graft, was doing well, but the disease kept progressing, and then came with perforation on one day, and quite a large one. So my colleague had to do a sort of a half, like not a laminar, but a full thickness graft actually.
Okay. Thank you. Thank you so much.
I have one question. Hello.
Yes, ma'am. Yes, Dr.
Yeah, yeah. Uh, like you showed one patient which was having this rheumatoid factor positive, but the patient was not having rheumatoid arthritis.
Yeah.
So, what is your systemic workup in such cases, like where you feel the systemic disease is associated? Like, what are the must investigation?
So I divide the investigations as for ruling out etiology and those that you need to manage the patient to start steroids and so on. So for ruling out etiology, the only tests that are relevant is to do an RA factor and an ANCA factor, ANCA. So the others are okay, like you can do ANA, whichever other accused, but they're all non-specific. So these are the only two specific factors that I do. And if I have a patient giving obviously some kind of history, then even, I'll just straight away refer to the rheumatologist. But sometimes without having any systemic condition, you refer to rheumatologist. The rheumatologist is not so onboarded with us to start therapy and so on. So I do a baseline, and for my academic curiosity also I do a baseline investigations. But mainly I'm just buying on an RA factor and ANCA. So the only important factors for me. And if those are negative, then I go ahead and the other investigations like the blood counts, everything else, Mantis tests and so on. All of these tests are only because if I'm managing or with my physician, we're managing the patient with oral steroids and then immunomodulators. So that's the reason for doing all the other tests.
Thank you.
So I think that was amazing talk, and this concept that we have to not use banana graft and rather use amniotic more often is extremely good, and I think very conceptualized also. Thank you so much, Dr. Somshila. Now, there is another question by Dr. Ashi Khurana. She is asking how to approach a case of PUK with fungal superinfection.
Thanks, Ashi, for asking the question. We've had that situation, of course. In those cases, I only suspend the topical steroids. The patient continues with oral immunomodulation, whatever is going on, and only suspend the topical steroids completely. And unfortunately, because we've used steroids and then there's fungus, so we might have to expect worsening and sometimes stick up these patients for a therapeutic graft. But the couple of cases that we have managed, they can respond also. It's not like all is lost. Only stop the topical steroids.
So there is another question by Dr. Kirti. She says that have you experienced peripheral ulcer post anti-VEGFs?
No, I haven't. I've seen that it's been reported or something like that, but I haven't on my own seen a case like that.
Okay, thank you so much, Dr. Somshila. And if there are any more questions to her?
Dr. SM, one more query.
Yes, sure.
Yes, sure.
These patients of PUK, when we do lamellar corneal patch grafts, like I did in few, so these, especially when it involves a large area, so they develop irregular astigmatism when the eye became quiet, or so we prescribe scleral contact lenses, but sometimes they don't like it. So if we want to do DALK surgery in these cases, they are not straightforward cases. So what are the preoperative, intraoperative, and postoperative precautions we should take? Eye is quiet, but can we go ahead? We are scared.
It's if there's a peripheral banana patch graft and then doing a small central DALK, first of all, I've actually never had an occasion to do it. And I guess the only thing is that I would make sure that, that the patient is on immunomodulators and proceed with the routine way in which you do DALK, but it'll have to be a small DALK. I've never had a reason to do it. I am at a loss to see what kind of case, because you would have to end up doing a PK once again. Because how would you apply the DALK part onto the patch graft area? So that'll be a little difficult. So it's an interesting question, actually. And about patient not happy with scleral lenses, they never are. So we have to make them happy or something.
Thank you. Thank you so much.
So Dr. Shalini, is Dr. Radhika Tandon here, or we can ask more questions from Dr. Somshila?
So she has recorded her presentation and she has sent her presentation. So we can start her presentation, and then later on, if needed, we can take few more questions.
Yes, sure.
So I would request Dinesh to kindly start the presentation of Dr. Radhika, madam. And before that, I would request Dr. Ruchika to introduce Dr. Radhika, madam. Although she is well known to everyone, still a little bit of introduction. Yes,
Thank
Dr.
you, ma'am.
Ruchika. Yes.
Yeah, it's a privilege to introduce Professor Dr. Radhika Tandon, Chief RP Center, AIMS, New Delhi, a renowned leader in cornea refractive surgery and pediatric cataract care, with over 350 publications and major contributions to stem cell therapy and eye banking. She has shaped the future of vision science in India. Her excellence has been honored with the President of India Silver Award, the RCS Edinburgh Gold Medal, and several distinguished national and international awards. So we are privileged to welcome a visionary surgeon and a great mentor, Professor Dr. Radhika Tandon.
Thank you so much, Dr. Ruchika. Dinesh, please start her presentation.
Good evening, everybody. At the outset, I'd like to thank the UP State Ophthalmic Society, particularly represented by Dr. Shalini Mohan, for inviting me to participate in this very interesting webinar. I'm going to cover a systematic approach using ophthalmic imaging for the diagnosis and treatment of corneal disorders. Essentially, when we're talking about ophthalmic imaging, one should be clear as to what is the purpose. So there could be various reasons for which you would undertake to image the cornea. It could be for diagnosis, it could be for documentation, it could be for decision making, follow-up, and prognosis. So it could be everything of these, or it could be partly, but I would like to emphasize that the importance of imaging in ophthalmic medical practice is extremely important as of today. Now, talking about imaging the cornea, you can either have real-time images, which is taken in vivo in real time. It could be a photograph, or it could be a cross-section, or there could be a kind of a mapping of shape and contour in the terms of topography, which is the surface of the cornea, or tomography, which is three-dimensional. So these are the broad aspects of corneal imaging. The importance of choice of various instruments or the procedure that you follow could also be affected by the speed, accuracy, and the reliability. And I would like to add to this the availability, and that there should be some logic or a scientific reasoning for following a particular protocol. When talking about in vivo imaging, that is real time with the patient there in front of you, it could be simply morphological, such as a simple, good quality clinical picture. It could be optical, or it could be an ultrasound, or it could be an image of the refractive properties of the eye, which could be placido-based, it could be a slit scanning, or Scheimpflug-based imaging of the cornea. And then we can also have a cellular level of imaging of the cornea, such as the confocal scan. Now, which methodology to follow, which instrument to use, when to use it, why to use it. So there could be various aspects to this. And again, there is no one clear answer. One has to have a clinical approach and a practical approach. But largely, it could be a routine practice of patient care. It could be important for medical legal purposes. And then, of course, there could be furthering of scientific knowledge through academics and research. Now, the basic premise is that you cannot do everything for everybody, and also it's not practical, feasible, or sensible. So you have a customization of the investigations depending upon the clinical need, the research need, etc., following a basic rationale. Now, clinical picture, for example, is extremely useful, as we all know. It can help, of course, for teaching, learning. It can help to diagnose, screen, and follow up, as you will find in future more AI-based systems. And then, of course, it's very valuable for documentation and record. When you're talking about real-time images, I mean situations where we are visualizing the cornea with magnification. So it could be a slit lamp photograph, it could be a cross section, as I mentioned, optical, ASOCT, or UBM ultrasonography. And depending upon the purpose for which you are taking the photograph or capturing the image, one has to pay attention to details such as the illumination, the focus, the magnification, the centration, camera exposure, white balance, whether it is going to be a static or a dynamic video-based image, so on and so forth. I'd like to mention this very famous quote that the eye does not see what the mind does not know. And correspondingly, we cannot take a good photograph if we do not know how, or if we are not clear what is the purpose of the photograph. Therefore, we've put together a compilation of standard slit lamp imaging techniques, and largely you should capture a photograph in all these aspects because you never know which aspect is going to be relevant later on. So a diffuse illumination, a direct optical section, zone of specular reflection, indirect illumination where you are indirect focal illumination where you shine the slit beam at one location and you focus or concentrate on the area just adjacent to it, retroillumination, and sclerotic scatter. So largely it's good to have the complete range of images for a patient, but of course in certain situations, for example, retroillumination you may not like to do if it is a very clear-cut case of vascularized corneal opacity, and there may not be any relevance of a retroillumination in your opinion. In cross-sectional imaging of the cornea in vivo, we have the anterior segment OCT, which is non-contact, it is non-invasive. using low coherence light wavelength interferometry, and you're getting a very good cross section. And with the newer machine definition, where you can see all the layers and document the thickness and various other parameters as required. Similarly, the ultrasonic biomicroscopy is extremely useful, particularly in cases where you may have an opaque cornea and you may want to image the anterior segment along with. Of course, there's a disadvantage in terms of the cost. It is a contact technique, a water bath, you have a high resolution ultrasound, and you have an oscillating probe with a linear signal transducer. And you can see the image the eye and the anterior segment and the cornea in great detail. So corneal applications, it can be especially useful in cases with opaque cornea and helpful for surgical planning and diagnosis in pediatric age groups such as the dysgenesis syndromes. Imaging the cornea in terms of its refractive properties, documenting the cornea as it functions. So here one could be mapping, because we do know that the contour of the cornea affects its function. So it could be topography, tomography, reconstruction, and three-dimensional characterization. And for this, we could have situations like suspected keratoconus, other ectatic disorders, refractive surgery workup, whether it's corneal lens-based procedures, contact lens fitting, post-keratoplasty, and so on and so forth. So this is important for contact lens fitting, as well as evaluation of the status of the eye post-keratoplasty, to give you some examples. Regarding the curvature, contour of thickness, you can have a combination of functions with these instruments. So you can have the anterior surface measurements using a Placido-based system and slit scanning OpScan. And then the Schemflug imaging system also gives you information or a mapping about the posterior surface of the cornea, which is important because it also contributes to the refractive behavior of the cornea and can be important in certain situations. So a snapshot comparison of the various devices one may have. So Placido disc-based video keratoscope or topography-based system, they can be very helpful for central and mid-peripheral corneal imaging and contact lens fitting. Then you have the traditional OrbScan, which was slit scanning based. It had images were scattered based on light scatter from both the anterior and posterior corneal surfaces. So this was the first instrument which gave the concept of a kind of a tomography, where you could have information about the anterior and posterior corneal surface, mapping, elevation, and thickness data. Subsequently, we have gone to higher level images using Schemflug imaging. So here are some examples of how the Placido-based systems work, where there are reflected rings which act like mirrors, which are reflected off the cornea. And from the contour of these rings, one gets an idea about the uniformity and the shape. The general principle is that wherever there is a crowding of the mirrors together, it indicates steepness. Whether they're more wide apart, it is a flatter cornea. And of course, a uniform symmetrical cornea will have symmetrical rings. Video keratoscopy would take this to a higher level with further analysis and sampling from different locations. So you'd have an idea about the maps at different locations with multiple images, as opposed to the traditional Schemflug, which was used to, the traditional Placido disc, which was a single reflection which was captured. Now, for the thickness or the tomography, you have slit scanning and triangulation. They are used to derive the actual spatial location of several points on the anterior and posterior corneal surface, where the beam of light scans the cornea, captures the image, it is converted into useful data. So a series of slit beams are projected, the image is captured, and then the information is computer analyzed to give you a detailed image. And understanding the map. So traditionally, the maps have been available in both 3D as well as flat imaging, where there are certain color coding conventions, where red indicate hotter colors and more steep cornea, and blue indicates cooler colors or flatter cornea. And these, the concept of elevated or depression or a flatter cornea is in relation to what is considered as a best fit sphere, which is constructed as to the basic baseline of the cornea. So a normal cornea is actually prolate, where it rises above the best fit sphere in the center, which therefore appears as a central island or a central hill on the topography map. And then it dips below the best fit sphere around the annular hill peripherally, which therefore gives you again a peripheral highland. So this is how it appears as a standard cornea, and vary depending upon the disease pathology. Coming to Schempflig optics, this has gone a level higher, where there are sagittal sections of the anterior segment. They are photographed using the concept of the Schempflig principle, which I'll explain to you later. This gives you a greater depth of focus, and there's a simultaneous imaging of the cornea, the anterior chamber lens. And the Schempflig principle is to get a higher depth of focus. It moves in a sequential pattern. It's a schematic picture where it goes across a plane at the section. And here we have different models, whereas the Pentacam is one example. We have no financial interest, and you can have hybrid, placebo, and Schempflig based device, which then produces the images for the anterior and posterior cornea. And it is a very quick rotational capture of the entire, which is then mapped in multiple points. And then you can use the way that the image is going to be, or the information is going to be presented, in terms of 3D reconstruction, maps, and so on, and a reference photo to indicate which is the axis or which is the orientation which is being considered at a particular view. So you have the patient data, you have the keratometric data, there's an anterior chamber analysis, and various colors therefore being created depending upon the requirement. As with all instruments, you need to check the accuracy. So you'll have the information, you have to check the quality of the image. But these are the standard maps which are used. We will have an axial, sagittal, or a curvature map, which will show you the dioptric values. Then you have the elevation map, which shows the elevation over the best fit sphere. Then we have the corneal thickness map, which is going to give you the pachymetric values. And then the front and the back elevation separately. So elevation on the front surface, there are certain values which are taken as a norm, and then based on that, you can consider whether it's an ectatic cornea, a flat cornea, and what other that would be involved. This is the typical detailed image that you would get, and you would look at the analysis and look at it carefully depending upon the reason for which it is being done, such as refractive surgical screening or follow-up of a case of keratoconus, so on and so forth. So you have the K1 and K2, the keratometric values, the astigmatism, and the back corneal back surface, and the so on and so forth. Then there is the concept of the Bellin-Ambrosio enhanced ectasia display. The idea being here that if you have a neutralization of the cornea around the thinnest point, you may be able to enhance any subtle ectatic changes. So the best fit sphere from the central 8 mm zone is taken after excluding all the data from 4 mm around the thinnest point. The premise being that in early keratoconus, one would expect that there is a change in the best fit sphere because of the abnormal value. So the averaging values are incorrect. So if you exclude the abnormal points and remove that artificial average, then you are able to enhance the discrepancy which is actually present. So you can combine the elevation based as well as the pachymetric evaluation. So as you can see over here, there is not that much of a visibility of the ectasia, but after excluding the values from the zone around the thinnest point, the premise being that keratoconus most abnormality starts around the thinnest point of the cornea, you will find that there is an enhancement of the appearance of the ectasia. So when this stands out, and this difference shown by what is called as the Bellin-Ambrosio display. So on top, for example, you have an image, and then we have the map, which is after excluding the best fit sphere, and you can see there is a very distinct redness showing the elevation. So the elevation map of the normal eyes looks the same normally, but if you use this Bellin-Ambrosio enhanced ectasia display, it is highlighting the abnormality which may be missed in. In addition to this, we can also get values spatially, looking at the spatial change. If you remember what I showed you with the Placido disc, in the area where the cornea is steep, the Mayas become closer together or more crowded. So the same principle here, if there is an abnormality of the cornea which is in the early stage and it is missed on clinical assessment, but if you are able to map the rate of change with spatial, space away from the thinnest point, it can be enhanced. So there is a horizontal axis which represents the location, a circle centered on the thinnest location, and red color is showing the curve of the examined cornea, and the black is showing you two standard deviations above and below the corneal thickness. So as you can see, if the actual rate of change or spatial frequency is going markedly outside this zone, it indicates an abnormality. So, which are the conditions where one would suspect keratoconus? If there's frequent change of glasses, there's defective vision, even with refraction, long-standing VKC or allergic conjunctivitis would be prone, refractive surgery workup, abnormal keratometry, slit lamp examination suggestive of thinning, and so on. So these would be the situations where one expect to do this mapping. So screening for corneal ectasia or keratoconus, corneal ectasia monitoring and treatment, refractive surgery screening and monitoring, post-keratoplasty astigmatism, evaluation and management, preoperative IOL selection, particularly if one is going for the premium IOLs, assist in contact lens fitting, ocular surface disorder evaluation, glaucoma evaluation and anterior chamber depth, cataract evaluation, index implantation, and corneal aberrations are few examples where this is highly essential, in fact. So now, to show you some examples, I would like to show you the full range of instruments, because there would be different situations where you may be faced with the possibility of having to see and analyze of images. So I don't want to be restrictive. So here, for example, are the topography maps with the orb scan. And I would like to again show what I went through very quickly earlier. That one is the topographic map where you have the anterior elevation, then you can have posterior elevation. So in different instruments, or the way you set up your system, or the clinic sets up its system, they may choose different permutations and combinations, but generally these are the four standard maps which are pretty universally used. So one shows the anterior elevation in terms of the anterior corneal surface. The posterior elevation, again, it is in reference to the best fit sphere. And then here is the curvature map, which is showing the dioptric value at different locations of the cornea. So if you look carefully at the posterior elevation map, you can see a central red zone, which indicates there is a posterior elevation, which is suspicious of keratoconus. If you look at the curvature map, there is a horizontal bow tie. So there is obviously quite a bit of astigmatism. And here it is a horizontal bow tie, and then here we can have a pachymetric map, which is going to show you the thickness of the cornea at various points. In addition, you get other information such as the white to white measurement. You can get the pupil diameter, what is the thinnest point, what is the AC depth, and so on and so forth. But it's always good to remember that it will depend upon the way the image has been captured, and also the standardization and the quality of the images. And generally, the values from one instrument are not directly comparable with those from the other, but in very gross situations, they would be pretty reliable to know what is the condition. So the axial curvature map is really the direct dioptric power, which is directly calculated related to the corneal shape, but they tend to average the corneal curvature, so some detail may be lost. There's also a tangential curvature map where the curvature is calculated from the neighboring points using a second derivative of the corneal shape, so probably useful for detecting irregular astigmatism and does have greater accuracy in the corneal periphery, and it can also emphasize the transition zone curvature changes following refractive. Now, a comprehensive corneal shape and strength analysis can also help to give you an increased knowledge about the corneal behavior. So this combined with the corneal biomechanics is available in the Corvus ST, which is Corvus Scheimpflug imaging, where you both have the topography, the tomography, as well as the corneal biomechanics. Now, coming to the cellular level, we have the corneal components. So one is the confocal microscopy, which is a non-invasive analysis of corneal microstructure and function. By non-invasive, I mean that it is giving you a cellular level or histological level information to a large extent without a biopsy. But it is a touch technique. It's not non-contact, but it is non-invasive. A scanning laser system is used with an optical sectioning ability, and it allows images to be taken at different cornea at great magnification. So you can see the different layers of the cornea, the epithelium, the subepithelial layers with the nerve fibers, then the stroma along with the keratocytes and the endothelium. And then the disease pathology, one can pick up additional abnormalities such as if there are microbial organisms such as fungal hyphae or acanthamoeba cysts, or even the change in the pattern you would get with different forms of corneal dystrophy. So the principle is that the image light is reflected in a mirror-like fashion off the optical interface between the corneal endothelium and the aqueous. So the principle, the image is giving you reflected and it is captured in high magnification. Regarding the endothelial layer, you can have specular microscopy where you can image the endothelium and count the endothelium using different strategies for counting the cells. Either we can have a direct counting method or variable frame method, fixed frame and variable frame, where you can detect the number of cells as well as the cell morphology, the coefficient of variation in terms of the cell shape and size, hexagonality for the cell shape, and size would be the coefficient of variation. So now I'd like to give you a few case studies of examples of how these images. So here we have a patient. As you can see, there is evidence of a keratitis, there is an inflammation, and there is a ring-like infiltrate in the cornea. So here one would have a differential diagnosis of fungal acanthamoeba keratitis, and this patient turned out to be viral keratitis, was successfully treated with acyclovir and topical steroids and cycloplegics and recovered fully. And the key distinguishing factor in this case was the absent sensations. And a confocal microscopy was done to rule out acanthamoeba as well as, and all you could see was activated sites, as you can as well. Another patient here of disciform keratitis. Here again is a little pathology, and so that was very suspicious of a viral keratitis, but over time it became increased in density. The patient was kept on follow-up for a long and with variable response was treated with antiviral, anti-acanthamoeba medication, and took a long time with a lot of waxing and waning course. And finally, was detected to be microsporadial keratitis on confocal microscopy, as well as on histopathology when we did the DALC. Here's another example of how ASOCT can be useful in management and decision-making in infective keratitis, where you can see what is the depth of the involvement, what is the extent, and how it is to treatment. So here are some examples from our textbook on corneal infection and inflammation. So here we have an example of a case of suspected acanthamoeba keratitis. So you can see it's very similar to the previous cases of viral stromal keratitis I showed you, and one could be make an error, and often they are misdiagnosed, and often patients are given multiple treatments simultaneously. Corneal sensations, as I mentioned before, is a very useful clinical assessment to which goes in favor of viral keratitis, and a severe pain or presence of active neuritis goes in favor of acanthamoeba. And as you can see here in the confocal microscopy, the diagnosis was clinched, where you could see the acanthamoeba and the patient could be given definitive treatment. Here's an example of a fungal keratitis, clinically very suggestive of fungal, but rather than waiting for 2 weeks to get culture positive, and sometimes in scraping, it may not be immediately positive on KOH. So here we can have a confocal microscopy, which is showing very clear the fungal, and the patient could be treated accordingly. Here's another example of a fungal keratitis showing the infiltrates and how the ASOCT can show the involvement and help in the diagnosis and planning of treatment. Thank you for your attention.
Thank you so much, ma'am, for your excellent talk on whole spectrum of imaging of corneal diseases. And we are indeed so thankful to you, ma'am, because your aunt is not well. Still, you managed. Thank you so much. So I have one question, ma'am.
Yes.
Regarding radial keratotomy eyes, now we get to see so many patients of cataract and radial keratotomy. So, which of the modality is the best to check keratometry in these patients?
Yes. So this is a very good question, Shalini. It's
Yes,
actually
ma'am.
quite difficult. So
Yes.
there is no ideal method because the refractive position of the cornea changes, and all the variables which are used as assumptions to come to a value of refractive index for the calculations, they go haywire after radial keratotomy. So what you have to do is there are several recommendations. So you can take the measurements from various devices, a standard keratometer, a tomographer, and then when you put it into the various formulae, you can do the various calculations with each and every value that you've got. So you'll end up with maybe 5 or 6 different IOL power calculations just but with different keratometries. And then again, you'll have different IOL formulas that you would use. You can also use online calculators. After that, what
Right,
you should
ma'am.
do is a tendency of the shift in the refractive index or the refractive power of the cornea to shift to the flatter side. So that is an underestimation of the actual power. So therefore, what it means is that if you go by the value that you get, you're going to get an IOL surprise on the hypermetropia side, which is always very inconvenient for the patient. So what you need to do is you need
Yes.
to go to the myopic side. So in a simple way, I would like to explain. Supposing you get 5 values, say 22 diopters, 23 diopters, 23.5 diopters, 24 diopters. So you will select the highest myopic side. That is, if you get 24 diopters and you have the lowest one is 21, you will select the 24 diopter power. And there also you'll go on the first myopic. So supposing in your calculation you're getting emetropic power of 24 and the first myopic is say coming as 24.5. So you'll select the 24.5. And of course, you'll explain to the patient that there is still a chance of IOL surprise.
Right. Thank you so
Is
much,
it
ma'am.
clear?
Yeah, very clear, ma'am. You explained it so well.
Okay.
Ma'am, if you don't
So,
have any other modalities and still you want to do a surgery, so with the keratometric value and the axial length, is there any rule of thumb which may help you?
Yes. So there are 2 ways. One is that if you're able to get a keratometry value, and axial length, of course, you will get. But if you're getting a keratometry value with your standard keratometer or an refractometer, then you can use it. But sometimes what happens is you get error or not getting a value. Then there are 2, 3 methods. One is you can use the previous a refraction. That means a patient who had, say, RK done and then for a long number of years didn't have a cataract and then developed the cataract. So if you have any previous refraction available to you, so then from that you can use it as an approximate estimate. Then if the cataract is not very dense and there is adequate clarity to try a refraction, then you can use put a contact lens and do a over refraction to estimate the astigmatism or the keratometric component of the cornea. So these are 2, 3 other methods, but they're not very practical and they're a little cumbersome, I must say, because as you're saying, if you don't have the devices, you possibly won't have the contact lens kit and you may not be very comfortable doing that as well. So then you just go by the keratometry and or any previous values that you may have.
But I would recommend that in today's day and age, you should be able to get access at least to in such a case, you should make the extra effort to at least get access to a value with topography, if possible. I mean, that much I think we have to try.
Okay, ma'am.
Otherwise, we can get it from some other center also.
Quite right. Yes, quite right.
Dr. Abhishek is having
Yeah, I'm sorry, the signal is a bit low here. So I'm sorry, I couldn't hear the question.
everything. Yeah. President, he says that topography is available, but is that he is having topography, but pentacam he's for pentacam, and he cannot manage with topography.
I see. You see, what the pentacam does is it is giving you, along with the anterior curvature, is giving you the posterior curvature. It's also giving you the thickness. But as far as and the only benefit of the posterior curvature is if you're planning a toric lens, because if you have a, with the rule or against the rule posterior astigmatism, that can affect the calculation accuracy for a toric lens.
Yes. Okay.
So I would expect that a person who's gone through this stage is not that, because you see, we're assuming that the person did not have that much of corneal astigmatism and has
Hmm.
now got the drop in vision mainly because of the cataract. So if
Hmm.
you talk to the patient and say that there is chance that you'll have to wear maybe a small power of glasses, then
Hmm.
because originally the patient had the refractive surgery for the correction of the power, and we're assuming that there was no like a heavy cylinder left. If the patient
Hmm.
already had a cylinder because of the original surgery, then you have the cylindrical power, which will give you some idea about what would be the astigmatism and so on.
Hmm.
So you have to
Right.
use a little
Right,
bit of
ma'am.
clinical
Yeah.
acumen and clinical assessment along with
Yes.
it. Now,
Yes.
so if you have access to a topographer and don't
Hmm.
have access to a pentacam, then that's fine. You can go by the values that you get because the surface, but then don't go for a toric lens because you could make an
Hmm.
error there.
Right, ma'am. Fine, ma'am. Thank you, ma'am. Do we have any other question?
Thanks so much, madam. Just
Okay, thank you so
brief
much
point
for
I
the
would like to.
opportunity. Thank
Our
you.
pleasure, ma'am. Our
Okay.
pleasure, ma'am.
Thank you so much, ma'am.
Okay. Bye bye.
Bye,
Thanks so
ma'am.
much, ma'am.
Thank you. Thank you, ma'am.
Thank you, ma'am.
So we have chairpersons and panelists with us. Do we have any comments from them?
So I would just like to say that in today's world, no matter how good your drawing is, but taking a clinical photograph of all your patients, especially those of ulcer patients, is very important because you need to compare the photographs at every sequential visit so that you
Hmm.
know exactly what is the size of the ulcer and what are the changes, what is the infiltration. So once you have a photographs with you, a sequential photographs, it makes you very easy to follow up the patients and manage your patients accordingly. So in today's day, the photographic system is also very cheap. In around 1 lakh or 2 lakh rupees, you can have a good photographic system. And I would request everyone to have a photographic system so that you can take clinical photograph of your patients and show them that your patient is improving.
Very true. We have Dr. Kamaljeet sir with us. Sir, would you like to say a few words? We also have Dr. Anil Srivastava sir.
My video is not working.
I would like to make a small comment
Yes. Yes,
regarding
Mitra.
the first presentation of PUK. Like before going for other investigation like rheumatoid factor or something else, we can get the basic ESR and CRP done. The ESR and CRP will help us to know whether like any systemic involvement, it is a chronic inflammation or it is acute inflammation. And in case of the CRP is much raised as compared to the ESR, it's going in favor that it might be a vasculitis and this patient needs to be referred early. It might go for a this corneal melt early. And if
Right.
it is a
I just wanted to respond, if I can.
yes, Didi.
I just wanted to respond to that comment
Madam,
on.
Dr. Somshila is answering.
Yeah. I just wanted to quickly respond to that comment on of the. It's a good what you said suggested is a good tip actually. You can do ESR, you can do CRP, But ultimately, as ophthalmologists, we have to decide based on the ocular features, so which includes the age, like you have a young patient, aggressive disease, bilateral disease. So even if the ESR is elevated, not elevated, whatever may be the CRP, I am going to treat the patient aggressively from the ophthalmic point of view. So that's the reason why, although I would do those investigations, I usually always do them, but I don't attribute much significance to them being negative or something like that. My management always depends on the ocular findings. And as I mentioned earlier, that if they have a systemic vasculitis, it is not presenting right now. They're not symptomatic for it. So the rheumatologists and all are not really onboarded to be very aggressive. So we have to guide them. So they can do all those investigations to monitor the patient. But from our perspective, as say, if I'm a general ophthalmologist, I would much rather decide whether I can treat the patient myself or I want to refer the patient right away. So if I want to refer the patient, I just do it right away and send the patient across. Of course, what you said is important if in a setup where you don't really have anyone to refer the patient to, and we are only treating the patient, then we definitely take the evidence from whatever investigation that we have, like you said, ESR, CRP, these are very easy to get done. And I completely agree with you that very high elevated ESR, very high elevated CRP is definitely indicative of some systemic inflammatory disease, and we should be more aggressive towards treating the patient with systemic steroids.
Thank you, ma'am.
So the main thing is that even if the patient is RA factor, NCA positive, other things, we have to look as per the condition of the eye. And maybe even if they are negative, we have to treat aggressively if we feel that there is a chance that the patient might perforate, that the cornea might perforate, or the patient might. So we have to treat accordingly. Yeah.
Abhishek, I would suggest that you have a few webinars on cornea since you are having this. The next step would be to see the bacterial ulcer and fungal ulcer, which is more common in our part of this country. So that would be an interesting thing because general ophthalmologists get these cases often. So that would be better. So next webinar,
Dr. Shalini, that
Yes, sir. Definitely, sir. We will definitely plan one on bacterial and fungal corneal ulcer.
So thank you so much. Thank you all. It's a good beginning. I am sure that a good beginning would end in a very good scientific academic meetings in the UPSOS. Thank you so much.
Thank you, sir. Thank you so much.
Thank you, ma'am.
Thank you very much.
Anybody else would like to comment upon anything? SP Singh, sir, you can speak. Anil Srivastava, sir. Shashank,
Excellent
sir.
presentation and a very good initiation. And I hope this UPS will go along and will lead this academic field. Thank you so much, sir. Thank you to everybody. And for our agile team also, the congratulations that have organized very excellent. The speakers are also very good speaker and excellent presentation. Thank you to everybody.
Thank you, sir.
And keep it up.
all your blessings, sir.
Thank you, sir.
Thank you so much.
Thank you, sir.
everyone.
So, if President sir allows, then can, ji, sir,
Okay.
can we close this meeting, sir?
No. Okay.
Okay. Thank you, everyone. Thank you, Dr. Somshila. Thank you, Radhika, madam, and all the chairpersons, panelists, and of course, President and Secretary, and all the members who have joined. Thank you so much.
Thank you.
Bye bye and good night.
Thank you.
Webinar. Thank you.
Thank you.
Thanks.